Okay, Dr. Nielsen, thank you very much again for the introduction and the honor to talk about a quite challenging and still a little bit controversial topic, which is the Alps. And I would like again to mention that I'm very proud to be here for my friend Rami, and I showed already these pictures yesterday, and I'm very happy that after we will have some talk about him. I just want to mention with this scientific contribution, if you look at his CV, you can see that every time since 1971 he was on the top of the new ideas, the challenging ideas, and his first paper was in fact on the radionuclide treatment of cancer, which at that time not many would believe in it. He was also involved in transplant, described living-related transplantation and how to take the left lobe. That was in 1989-88. And we are talking about the same topic still today, and still many things to solve in this area. So what I want to talk is about these Alps. I will describe it later what that is, but just to start, we are dealing here with an intervention which is quite complex, and this is for rare indication and only for extensive liver disease, as you may see here in this patient with diffuse liver metastasis. So this is the population and target of patient that we have for these procedures. What I will move here in this talk is how this procedure was developed, a study that we compare with what exists before, as we always do in medicine. Then the study from the MD Anderson, who was challenged the Alps. Then the first result, that's the first time, in fact, that we report on the registry. It's never been done before, and a randomized study that we are initiating. So what we were doing before in this was a two-stage procedure. So to take so many tumors or large tumor in the liver, we need two operations, and the standard treatment here that was done over the past 10 or 15 years consists of two stages. So the first stage, we do a portal vein occlusion, could be portal vein embolization, or if we do surgery, ligate the portal vein and we'll take out or clean here the left side of the liver. We will wait a month, sometimes 2 months, sometimes even 3 months, that we achieve what we want to achieve, is that the small liver that we cannot remove the first operation is too small, that it will grow, it will function better. We expect to have something more than 30% of the volume of the liver, and when we achieve that, then we go for the second operation, which is a curative resection, when we are able with this strategy to remove all the diseased liver. Now, the issue, if we look at the data on that, is that, in fact, to go from stage 1 to stage 2, only 60 to 80% of the patients who underwent stage 1 will eventually get stage 2. That means 20 to 40% will not do it because the liver doesn't grow, so you cannot go safely for that, or the tumor will grow during the meantime, and you cannot go. So these patients do not benefit at all from this surgery. That's an important figure to remember, because the Alps has not this shortcoming. And that's what it came in 2012. So we are very recent here. Publication in the Annals of Surgery from Germany. Several centers in Germany put together this new operation that I will describe for you now. And I was asked here with my colleague from Buenos Aires, Dr. Santi Bañez, to write an editorial on that. We had performed in meantime 1 or 2 of these operations, because we're aware of that. And that's where we came with the idea of an acronym for that, and we suggested to call that Associating Liver Partition and Portal Vein Ligation for Stage Hepatectomy, and that's the abbreviation HALPS, which in fact has been later adopted. We were a bit accused that there was some geographic favoritism with this operation, but we want to have something that people can remember. So what is the ALPS? The ALPS is basically the same operation I just showed you before, but there is an in situ split. So those who do transplantation or living know what that is. So we do exactly the same thing, portal vein ligation, and here we will completely split this liver after portal vein ligation. And here what happened is very short period of time, 1 week, we will have a dramatic regeneration. That was very well described in the German study here. So a dramatic increase of that. We will again to have the more than 30%, and we can do stage 2 within a short period of time. We don't need to wait here 1 or 2 months, but it can be done within 1 week or 10 days in most of the cases. I just show you here to illustrate the type of patient. This is the first patient we did in our center in Zurich. A young lady with a rare disease here, diffuse in the liver, with the primary tumor was in the brain for this hemangiopericytoma, operated a long time ago, good condition, but this poor lady was rejected in many places because who wants to go to remove this kind of tumors? And we decided, if we look here at, I think some animation, that's the remnant liver, so that's what we have to leave behind if we go for surgery. 20% or less, you know here that if we go for this surgery, there's a good chance that this patient will not survive. So here, if we go for these HALPs, that's what we did. So 7 days or 1 week after we did the in situ split, you can see here the in situ split, the liver is part into it. We have a dramatic increase. In fact, from 80% now, the remnant liver is no longer 20, but 40%. And then we can go for the third stage, 7 days after second stage, after curative resection, there is no tumor left here, and there is another increase of the regeneration here by 170%. Very impressive for those who work in liver surgery. We've never seen that before. At least that was our observation, that we have here something very new, which enabled in situation like this young woman within a week to cure this patient from the tumor. This is another example here. When we do portal vein ligation, I show you 20 to 40% will fail. So we did in a few of these patients with other centers here this procedure after failed portal vein ligations. And here this is an example of what we did here. So here this is, you have here before the surgery, we have a very small remnant liver here for this tumor that this patient have here. And then the remnant liver here will be about 23%, very high risk for this patient. After the split, you can see here with the X-ray, the split, the radiologist is a bit worried when he see that. He has not seen that before in the X-ray. So we do the in situ split with a dramatic increase here to almost 50%, which is an increase of 70%. We can go ahead after 1 week for the surgery, and you can see here the remnant liver free of tumor here after 1 week of surgery, with again a dramatic increase in regeneration after this. That's just the way it looks like during surgeries. That's like the living donor liver transplantation. Here we would split the liver in two. That's what's left here. We have the portal vein here, let's say ligated, with only the artery going on this side, which is full of tumor, and this side which should be free. Then we have the normal supply here. And the second stage is supposed to be very simple. After 1 week, there is not too many adhesion. Reality is sometimes different, but at least this is the idea. So the only thing that's left is a portal vein, a bile duct, and a hepatic vein. So here with stapler, we can do here a relatively quick hepatectomy in this second stage. So that's where we were relatively rapidly, and those who read the literature knows that not everybody is happy with that, and there has been a lot of reaction on that, particularly on the other side of the Atlantic in the US, and particularly from the surgical oncologists more than the HPB surgeon who are involved in liver transplant. This may be a simplification of the discussion, but that's an observation. And there has been many letters that were submitted to the Annals of Surgery here, and I would just go through a few of these letters to show the concern here by the very good group from MD Anderson, and we've done many work together with Nick Voted, so this is only an academic discussion here. Now, he was very surprised because the morbidity was very high, mortality 12%, and that was much too high for that. He liked the idea of waiting, because that's a way to test whether the tumor is aggressive or not, so doing too quickly may not be good. And that also enabled to select the other technique, what he was suggesting, that the liver will regenerate or not will give us the risk for surgery, and the high hypothesis that this huge regeneration may not be good for the cancer, and the cancer may even grow up faster. Daniel Jack from Strasbourg, also the same, was worried. We sent a letter, so these people had concern, a letter about morbidity, mortality, and they mentioned here that was that with portal vein embolization, if you take segment 4, you may achieve the same degree of regeneration, and he cautioned, and here was right, that if you have heavy chemotherapy, that could be a problem with this procedure. Here, Jacques Belghiti did a few of these operations. He had 50% mortality, many bile leaks, but when we talked to him, he was ligating the bile duct to even increase regeneration, which we thought could only increase bile leak in the situation. He also observed, which is also correct, that volume size is not exactly function. It could be a difference, and that the way he was doing it, at least, that in the cholangiocarcinoma you may violate the non-touch technique, which here I think it's not completely. So what are the potential benefits? Well, I mean, I showed that the possibility of the small remnant liver to increase really much faster than the other technique. We can be more aggressive and maybe enhance the R0 resection, decrease time between the stage, so decrease progression of the tumors. This is only a one hospital stay. Patient don't need to go, be sick, and come back often. That's also an hypothesis. When we transect the liver, you may prevent the tumor to go from one side to the other side, and that it was already demonstrated in a few cases that if you fail with the standard technique, you can still use that as a rescue. I will not go to all this paper here, but it was a number of papers, and they are still coming, very small case series from different places of the world. What is reported is a typical publication bias too. People report the success, so they came, they showed the success. Some have done even that laparoscopically in this, and no comparison. The only one who appeared was with 7 cases to compare with the other one, and that's why we did this study here again with a few other groups from Germany, from Buenos Aires, from Canada, and us, and we wanted to compare our series, previous series of portal vein embolization ligation versus this new procedure here, and now it's a retrospective analysis here, and we decided to have as our endpoint the ability of achieve a R0 resection, since this is the only chance of long-term survival in this patient. We did a sample size calculation. I go quickly for time reason here. So we have 4 centers. At the end, we have 131 patients. We had to exclude a few because of data, and we have 83 in the conventional group, 48, 51 with portal vein embolization, and 32 with surgery, portal vein ligation, and cleaning of the other side. Also going quickly, that's the center and the patient we enroll in that. You can see that the majority here are colorectal liver metastasis, but we have many other indications here. The age between the both group is about the same. You can see here that about half have heavy chemotherapy or chemotherapy before. In comparing this group, they were usually very large or multifocal tumor, 2/3 of multifocal. Number of lesion was also pretty high in these patients. And here is the result of that we show that in the portal vein ligation, 66% of the patient had R0 resection after 3 months or 6 months, while this number was 83% in the AMS procedure, which gives us an odds ratio of 3.3 times. If we had just done with statistician, of course it's retrospective, we can criticize that, but that was the first evidence here that HALPS is better than the standard therapy to achieve R0 resection, at least in the short term, no long-term data, of course. Now, the other issue with that is the morbidity, mortality, and that was the data. 6% is not 0, 6% in the conventional group, they are sick patients, 15% in the ALPS. So, of course, that triggered a lot of discussion. The patient who did not reach, all patients in the ALPS reached stage 2, we embarked in that, they were able to do, while 25%, which is consistent with the data before, never reach the stage 2. So they were offered a pretty big operation of 1 in 4 patients for nothing, and that need also maybe to be balanced in the discussion. This graph here just show you the time to complete resection. You don't need much statistic here to see that we have a procedure, you can do it quickly and effectively, and the other one, it takes 3 months, and in some series even more than 3 months. The data about regeneration here, just when we compare that, we have CT scan in this patient, and we can look, and each of these curves is an an individual patient, and you can see here that regeneration was achieving in all of them. There was no patient, a different degree, while here you have patients that have none, a big difference. And when we calculate that, assuming that it was a linear growth, with the Alps, there was about 35 cc per day of increase compared to the other of 3. So a really dramatic difference here in the regeneration of this liver, again, that we have never observed before with any other procedures. Now, the group from MD Anderson, who is also academic, did not believe this data. We're still at the stage a little bit of believer here, because we can criticize that. And they perform a study, a very long title. So for me, when the title is so long, I'm suspicious. Usually we like short title, but basically they wanted to compare the portal vein embolization. They're probably one of the best centers worldwide in doing this portal vein embolization with the series from the German series. So that's already not very fair, because you take the first series of learning curve with the huge experience of the MD Anderson. I will go relatively quickly to that also for time reason. Basically, they have 144 patients that could match with this patient from Germany, and there was embolization, extensive embolization of the right and the segment 4 in this setting. Here I will also not go much in detail for that. That's the 144 for the portal vein, 25 for the Alps. But if you look at the real data, there is no difference in morbidity and mortality, maybe due for sample size or whatever, but absolutely no difference. There was some difference in bile leak, sepsis, etc. Again, the learning curve, we've not observed so many after the initial series, and the data was perfectly collected, maybe not in the other side. But now if we go again with the 144, you can see that in this series on MD Anderson, there was many failure. In other words, for different reasons, progression of the tumors or the liver doesn't grow, and at the end they had only 104 patients who underwent stage 2. So most of these patients, or not most, a third of these patients could never have the 2 procedure and a chance of cure. And if we look here at the survival, you can see those of surgical case, always the same thing in medicine, that the result is not bad, but those who could not have stage 2 have a very poor outcome in this setting. So about 30% never underwent. And when we look at the series of the registry that I will show you before, we have 200 patients, 98% of the patients entered in the registry eventually got the stage 2. So here that was the conclusion here, that the ability, so based on its ability to select oncologically resectable patient and superior safety and efficacy, etc., that portal vein embolization remained the gold standard. And when we look at the data, then we have to really wonder whether this conclusion is correct. Now, when you do a new procedure like that, complex, where do you go? So we decided, again, with a few centers to put together a registry that we call the Alps registry here. And since last December, so a few months ago, we had 250 patients from 56 centers that put patients in this registry. And we decided we will present that in 2 months for the first time, the European Surgical Association. But for the purpose of this talk, I took some data here. So we have 202 patients where we have enough and complete follow-up. At 3 months we could look. And the question that remained, what's really the morbidity, what's the mortality of this procedure, and is this risk factors? Are we doing the procedure in patients we should not do it? So that's where we go to the registry to look at that. So here I go to be quickly to that. You can see here that the majority were for colorectal liver metastasis, but there is many other indications, HCC, cholangio, etc. What we have here, the age is 60, the median age, about the same we had before, and 70% of these patients had preoperative chemotherapy before started the Alps. Here also there is the different volume. You can see here the volume was pretty low at the baseline, and prior to stage 2, so at the end of stage 1, there was a dramatic increase. So this registry really established or demonstrate the power of these Alps in inducing liver regeneration. At the time here, you can see 7 to 15 15 days, people were waiting about 10 days before going to stage 2 in this. Now, important data, 98% achieved stage 2, so most patients enrolled in that achieved it, and the mortality in this registry is 9%. So I'll let you interpret this and what it means in this, and then that's the risk factor. We found risk factor, blood transfusion, the duration of the operation of the first stage, the age was important, and whether it was another indication that colorectal liver metastasis in this setting. And if we look at here the complication, which is complication including death, that there is, according to the indication, again it's a registry, but the best group was the colorectal with only 21, which is the only serious complication in this group. If we combine here the different variables, we can see here that if we take this group here, the last one here, this group here, so relatively young patient, less than 60, with colorectal liver metastasis, then the complication rate is only 16% combining both stages, which is not, but it's 50% in the risk older patient with non-colorectal liver metastasis here. Now, if we take the best group here, again, the hospital mortality is 4%, is even less, that was reported before, and 90-day mortality 5.1%. So here we have, with this subgroup at least, very good result, or result that match any other procedure, and I think this is new tool to develop and to go on these ALPS. And here if we look at some survival, that's the first time we have some, not long-term, but 2-year survival, and we can see here that the group of colorectal liver metastasis and young, they have a 2-year survival of 75%, which is certainly interesting data to follow up in the future. Now, if we look at how this compares to other two-stage procedures, this data from the registry, if we go back to some publication from the MD Anderson here, is just to show that if we look at that, they match, at least on paper, seems to be quite the same population of patients. If we take the colorectal liver metastasis, this is the good group, and if we look at that here, you can look at here at the survival. So on the right side, you can see again that if they have or don't have the surgery, there is a dramatic increase. And on the other side here, the difference in survival between the colorectal liver met and the non-colorectal liver met. And if we compare this with the group that was published in Journal and JCO from MD Anderson, we have exactly the same survival for those underwent surgery. But again, the difference, and I make the same point, that a third of the patient never underwent stage 2. So there is here, for the same result if they underwent surgery, but if you go intent to cure, then there is a difference, since 98% of the patient can have this HABS procedure. And here, in terms of figure, the disease-free survival at 1 year in the study from MD Anderson was 40%, 60% in the Alps, and 3 years we don't have data. I think they're still open for and we need a randomized controlled trial, and that's where we are going for the randomized controlled trial. And just in the registry, there is many modifications, and that's also a good place for that. For time reason, I will not go to them, but you can basically skip only 1 segment, 2 segments, etc. And a lot of fancy things have been done that are in the registry. Even this proposition from Spain, rather than in situ split, they do like packing, a ligation. They report 5 cases, and they could show by just looking this technology here, that is just ligating a little bit this, we can also increase regeneration from this. And now we are doing also partial. I would just show you, to finish, a few slides from experimental data. We believe that the data may be not a complete transection, but a partial transection, where we're probably safer and achieve the same degree of regeneration. And I know that a few of you have done these ALPS, and I think it's important to register so we can go further. We have initiated a randomized controlled trial here. I will also not go in detail. We have but did an amendment for this study. At the beginning, we wanted to take basically any patients, but now with the registry, we want to limit to colorectal liver tumors in order to be able to compare that with other study, and we'll be a bit more careful with the biopsy, etc. And we are going on with this randomized study, which is multicentric and can be done with among different centers. And finally, when we are academic surgeon or try to be, we want to understand the mechanism. What is that we observe these regenerations never seen before, and we have a high morbidity. Can we go and understand a little bit better? And here what we can do is a mouse model, and I'm lucky to have a lab and very smart fellows, and one is doing in fact a PhD on this topic and develop a model on this. So that's the mice liver here, which is of course different than the human, and can do here mimic a ALPS procedures by doing an in situ split here and letting that will be the future remnant liver here in the liver, and all the other one there is portal vein ligation to try to mimic what's going on in the human, and that the step 2 is to remove everything and to let only this part of the liver which hopefully will regenerate here. And here the data. So you can see here that the ALPS in the mice here, and this is we can see also at day 1, because the liver in mice regenerate much faster. At day 1 here, you can see that the ALPS compared to all other group, portal vein ligation alone, is dramatically more than any other thing. So we were able here to develop a model in mice which mimic what we have done in human. Usually it's the opposite. We start from animal and we go to human, but here we go to the clinic to the benchmark. What are the underlying mechanisms? So I just summarized several experiments. That's the in situ split. You can see in the middle of this mice liver how it works. And we postulated here that what's happening is the release of growth factor or something due to this injury, and not just the interruption in the portal flow between the right or the left lobe in the human. So what we did the same model with portal vein ligation, but we had not done the transection, but we did injury, the same type of injury on different organ, kidney, spleen, and the lungs. And when we did that here, we observed almost exactly the same degree of regeneration that the standard ALPS. So in other words, if you do portal vein ligation plus an injury somewhere else, this combination induces regeneration of the liver. As another set of experiments, we took the plasma from the ALPS mouse and we put in a mouse who has no ALPS to see if there is something in the blood that can be transferred to these mice. And indeed here, to a lesser degree, but still highly significant, you can see here that just the portal vein ligation with the plasma is almost the same as the ALPS. And here's the demonstration that there is something in the blood that is released that causes this growth of the liver. What is it? Is under investigation. We still don't know exactly where we are. So I go to the conclusion here from this first ALPS. I mean, number one, I think we have demonstrated now in the world by many groups that we have an accelerated and unmatched liver regeneration. Now we need to know how to use it safely. That we can remove large tumor in a better way. At least there's some evidence that the previous techniques, so more chance to R0 resection. We still have higher morbidity and mortality. I think this is confirmed in many studies that if we do that, just another indication, we will have higher problem. Best indication is clearly patient with colorectal liver metastasis, and if they are lucky to be young, that we cannot change, that may result in much better result, and that's where we have today clearly the best result. The randomized trial will be limited now to colorectal liver tumors, and all the other cases we hope will go in the registry. And from this mechanism, maybe we identify something else. We don't need to do this big surgery and can just manipulate by understanding the mechanism, but we are not so far yet. So I thank you very much for the honor of presenting the ALPS in honor of Hamid Pierre-Alain. Thank you very much.